During this summer, we were able to present the Aortic Diseases Guidelines of the European Society of Cardiology. The truth is that it has been quite a hard but fantastic 2-year project involving not only the European Society of Cardiology. We worked closely with the European Society of Cardiothoracic Surgery to ensure that all guidelines and recommendations align with this society, and also in accordance with the European Network of Rare Vascular Diseases, known as VASCERN, the European Society of Vascular Medicine, and there has also been representation from the European Society of Vascular Surgery, which, although they do not endorse documents outside their society, we did have representation from vascular surgeons, as you can see here, and especially with representation from the European Society of Vascular Medicine. These guidelines, encompass and unify the update of the peripheral vascular guidelines from 2017 with update of the aortic diseases guidelines from Despite the initial controversy over why to combine them, I believe it has ultimately been positive because, as we state in the introduction of these guidelines, both the aorta and the peripheral vascular system are part of the same group of vascular entities. They are completely related. Combining these guidelines allows for the evaluation of the entire vascular system as a whole, as if it were a single entity, and it also avoids compartmentalizing specialties, enabling a significant group of specialists to collaborate when evaluating patients with different vascular diseases. From this comes the first recommendation in the guidelines. When assessing a patient with any atherosclerotic involvement of the cardiovascular system, we must evaluate them entirely as a single entity, considering the impacts at all levels. In complex situations, this patient must be treated by a multidisciplinary team at a specialized facility. Particularly when faced with challenging and biased decisions, clearly placing the patient at the center of the surgical decision-making process and reaching a consensus with them in the therapeutic strategy. In the guidelines, we focus not only on the diagnosis and treatment of vascular diseases themselves, but we also highlight follow-up, as there is the least scientific evidence on monitoring these patients. Many follow-up algorithms assist in managing these patients, and prevention is also a key focus, both from the perspective of medical treatment and from the standpoint of quality of life management, lifestyle, physical activity, and changes in risk factors that the patient must adopt to prevent the emergence or progression of cardiovascular diseases. And more data to demonstrate that the cardiovascular system is indeed unique and cannot be considered as isolated elements, as this data proves that vascular involvement is multifocal, grows exponentially as age increases, even if symptoms are more asymptomatic or atypical. Women will also be very impacted, usually more than men. From a cardiology standpoint, which is our focus as specialists, we should note that when a patient, for instance, has carotid atherosclerosis, we might see them after a stroke, or for another cardiology concern, we must keep in mind that this patient could have up to 60% coronary disease or 20% peripheral vascular disease, or the opposite, and we know this from our vascular consultations. A patient with vascular issues may have coronary involvement in 70% of cases and significant carotid disease in 20% of cases. Thus, the combined management of these patients is quite intriguing. Due to my specialty and time issues, I will focus on aortic diseases. When do we perform screening for suspected aortic diseases? The first recommendation is that clearly I will explain the screening for ascending thoracic aortic aneurysm later, However, lifestyle changes and healthier living, improvements in diet, and especially a marked reduction in tobacco consumption have changed the incidence of abdominal aortic aneurysm, and these recommendations have been updated, and it is now suggested that we should screen for abdominal aortic aneurysm in male patients over 65 who have smoked to reduce the risk of aortic rupture. However, regardless of whether the patient is a smoker, if the patient is male and over 75, it is recommended to conduct screening for abdominal aortic aneurysm. However, if she is a woman over 75, especially if she smokes or has high blood pressure, if a first-degree relative has had an abdominal aortic aneurysm, first-degree relatives should get screened starting at 50, not earlier. They should undergo screening to rule out abdominal aortic aneurysm unless there is a clearly identified cause responsible for the aneurysm in that first-degree relative. Opportunistic screening, meaning screening done when the patient is referred for another test, means that if a patient with peripheral vascular disease comes to the hospital for an ultrasound of their peripheral vascular disease, all patients with peripheral involvement should be screened for abdominal aortic aneurysm. And for those undergoing a transthoracic echocardiogram, if they are men over 65 or women over 75, they should undergo screening for abdominal aortic aneurysm. In this hospital, we always try to perform the subxiphoid EC plane and examine the abdominal aorta in all patients, especially at these ages. Another significant chapter addressed in the guidelines, and that has always been used in other guidelines, such as those for acute coronary syndrome, where we are very meticulous in managing antiplatelet treatment. Risk factors have been largely overlooked in aortic diseases. There is a whole chapter dedicated to medical treatment for patients with aortic and vascular issues, aiming to prevent the onset or progression of the disease. And here we also worked with the other guidelines that have emerged this year and last year, indicating that we must control blood pressure, following the hypertension recommendations from this year. There should be proper glycemic control, although in the case of aneurysms, diabetes might be a protective factor, but not in other conditions. Cholesterol should certainly be controlled, just like in acute coronary syndromes, because it prevents the worsening of abdominal aortic aneurysms. There is proof that it slows the progression of aortic aneurysms of the upper aorta, and certainly making healthy lifestyle changes like eating well and losing weight, working out for at least 30 minutes 3 days a week, and avoiding harmful substances. This emphasizes that these patients must receive the correct treatment, and I have also summarized how it can impact cardiovascular health. When we see a patient with vascular or coronary disease, if the patient is asymptomatic, there would be no need for percutaneous revascularization of the lower extremities. However, as cardiologists, besides referring them to a vascular surgeon, we can intervene when a patient has peripheral artery disease. For intermittent claudication, we should start them on low-dose aspirin, similar to cardiology practices, to specifically avoid major cardiovascular events, not only related to the limb, but also to always emphasize that the patient must follow up with exercise and lifestyle changes to avoid the progression of the disease, and certainly refer them to a vascular expert. As I said, I would center on the aorta aspect by specialty. And to note that from the angle of aortic condition, the first concept we define in these guidelines was to clearly separate that the aorta is divided into different territories, such as the ascending aorta, the descending thoracic aorta, the arch, and also that these different areas are divided into segments that we should learn about because they have important therapeutic implications. It is different if a dissection has an entry point in segment 4 compared to segment 1 because the surgical approach will change. Furthermore, the disease's extent will clearly impact the prognosis depending on how many segments are involved. Obviously, our determinations will be based on the diameter, so I won't go into detail about it since it impacts more those in imaging. However, in the guidelines, we establish a whole series of rules on how to measure the aorta to ensure reproducibility. In order to strive for maximum homogeneity when determining the diameter, which will ultimately be the value that defines the approach taken, therapy for a patient. Furthermore, we established that the transthoracic approach will be, and the echocardiogram will serve as the main examination when evaluating these patients. But we also established that both the CT scan and the MRI will have a Class 1 indication in the approach to patients with aortic diseases. This, of course, depends on the availability of the technique and the expertise of each practitioner involved centers. Thus, the next question is, after determining a patient's aortic diameter, when should we set the indications for surgery? Well, clearly, just as we are currently doing with a Class 1 indication, when a patient has an ascending aortic diameter of 55 millimeters or greater, we established that there is an indication for surgery. Also, as a new aspect, the American Aortic Diseases Guidelines from the 22nd meeting had already mentioned this. For patients with dilation of the ascending aorta, low surgical risk, and a diameter above 52 millimeters, if the patient is at low risk and the center has experience in surgery with a Class A indication, we could establish the indication for surgery. As for surgery, as shown in this second indication, repair surgery is set as the reference procedure if feasible. Above repair surgery, if we have a patient undergoing aortic valve surgery, the ascending aorta must be replaced if it is over 45 millimeters. If the patient is low risk, and if the patient has higher risk, then it should be at 50 millimeters. Where does the indication to lower the surgical threshold to 52 millimeters originate? Well, this fundamentally comes from the fact that the risk of dissection depends on one hand, the risk that the aortic diameter poses for generating a long-term aortic event, and also the event of the surgical risk associated with that patient. In essence, it needs to be a balance between the risk of complications and the surgical risk. Initially measuring an axial section, the Yale group in 1997 established that the point where the risk of complications at the aortic level began was mainly when the patient measured 60 millimeters. Therefore, an arbitrary cutoff point was established that to avoid the patient reaching 60 millimeters and having a 30% incidence of aortic dissections, the cutoff point was set at 55 millimeters. However, later other articles began to be published in which it has been seen that a diameter of 55 is not the best predictor to decide if surgery on the aorta should be performed, especially because it has been observed that the highest incidence of aortic events occurs at diameters between 50 and 54 millimeters, with a mean of 53 millimeters. And also that normally the diameters were established when the patient presented with dissection, and this is when it was decided what diameter the patient had at that moment of the dissection. However, we know that the diameter the patient had prior to dissection is usually 20 to 25% less, because with dissection there is an aortic expansion, and thus the diameter the patient had before dissection was smaller than the one during presentation in the acute phase. Moreover, after 2014, with advanced imaging techniques that are more precise with more complete patient series and no longer measuring diameters axially, but measuring them in double oblique as we do now, a trend appears, also encouraged by the Yale group, in which they indicate that we ought to make a left shift in aortic surgery recommendations towards smaller diameters, reinforced by studies like this one, where it is already seen that the highest incidence of dilation primarily occurs at diameters between 50 and 54. millimeters. Moreover, in significantly larger populations, a high risk and increased risk of complications is noted also significantly when the diameter falls between 50 and 54 millimeters. And other series reveal that the surgical risk notably increases starting at 50 millimeters. Thus, this is why guidelines start to recommend a diameter change at 52 millimeters. Furthermore, as we noted, there is a reduction in complications or post-operative mortality, along with better surgical techniques. Greater surgical experience at these centers has led to a decrease in mortality from 4 or 5% in the 90s to the mortalities we have now, especially in high-volume centers. And this can be discussed later in the discussion. In these guidelines, we discuss a lot regarding high-volume and low-volume centers. We have mortalities that fluctuate around. They are less than 2%. And we also know that when the patient is operated on, their life expectancy and quality of life will be normal and positive, which allows for an early surgery that results in low mortality risk and good quality of life moving forward. Yet we understand that diameter is not the only factor predicting cardiovascular events. In the last few years, a multitude of studies have emerged indicating that other parameters beyond diameter have implications for prognosis. On one hand, we recognize that the height on the body surface of an obese individual is different from that of a truly thin person who is only tall. Thus, the concept of height is also introduced, and in this case, we have the concept of diameter indexed by height over 32, as it is also a predictor of aortic events. The aorta's cross-sectional area divided by the patient's height, also above 10, is associated with a higher rate of events. A new concept is introduced, which we will see later, that is the aortic length, which I will explain why. Greater than 11 is also linked to events, and also obviously the dilation rate with different thresholds for the ascending, descending, or abdominal aorta segments. And also, as we will see later, the morphotype. It is different when the root dilates compared to the ascending aorta, with a worse prognosis for root dilation than for ascending aorta dilation. Clearly, using the index diameter is preferable, so we can utilize the z-score in almost every patient, especially those at the lower limit of body surface area, particularly shorter individuals or women, keeping in mind that it should be introduced more. The concept I mentioned regarding diameter arises from the knowledge that for some time when a patient dilates the aorta, not only does dilation occur in terms of diameter, but the aorta also expands and it also elongates. It has been observed in various studies that aortic elongation is also a predictor of mortality. Here in this study, it was observed that in patients before dissection, when we examined various parameters, when the aortic diameter was larger of 55 millimeters, sensitivity was 4%, but we saw that the length had an even greater sensitivity of 28% likelihood of developing an aortic dissection. In this study, it was observed that the incidence of risk was greater than the incidence of aortic events increased exponentially when the length of the aorta was greater than 11 centimeters, which is why this concept has been incorporated into the current guidelines. Another important topic is where the dilation occurs, whether at the aortic root or at the ascending aorta. We know from embryological studies that the ascending aorta and the root originate differently, thus they can exhibit different behaviors, and there are already studies showing that the dilation of the root, notice that, and I have cut off the part above 55 because they are obviously operated on, but the dilation of the root shows much more red and orange, meaning much more danger and a higher incidence of aortic events even at smaller diameters than when dilation occurs in the ascending aorta, meaning we have known for a long time that dilation of the root is associated with more events than dilation of the ascending aorta, and this study from IRA data studied patients who had type A dissection and checked what their aortic diameter was before the dissection, and they observed that when the dilation was of the root, dissection occurred at smaller diameters, unlike when the ascending aorta dilated, which dissection happened with larger diameters, further emphasizing that aortic root dilation has more important prognostic implications, including all these risk factors, because when a patient has any of these factors, we then move to a surgical indication of 55 millimeters. But we move it to 50 millimeters when dilation exceeds 3 millimeters and there is resistant hypertension, meaning more than 3 drugs, short stature, the phenotype of the root, and the length of the aorta. Patients who are young or clearly women who may become pregnant due to the risk of rapid dilation during pregnancy. About the bicuspid, I will be brief. We introduced the new nomenclature from 2021 into the guidelines for uniformity. To use the same nomenclature and truly know which morphotype we are talking about, establishing this as the official nomenclature for patients. Bicuspid, and clearly define the diameters where aortopathy occurs in patients with a bicuspid valve, whether at the ascending aorta or both levels, root or at both levels, as it also emphasizes that if the root is affected in patients with a bicuspid valve, the risk of complications of an aortic event will also rise. The risk of aortic events will be greater. I won't elaborate, but I will conclude that we will use the same criteria for aortic aneurysm for bicuspid valves because having a bicuspid valve has not been related to a higher incidence of events during follow-up. Therefore, surgery will be indicated for those patients with a bicuspid aorta greater than 55 millimeters, and when root dilation occurs in this type of phenotype, just like in patients with trileaflet aortas. It is advised that the root phenotype represents a higher risk phenotype, and here with a higher indication class, set the indication for surgery from 50 millimeters. An indication we have included this year, which I know Arturo, for instance, did not fully agree with. It is recommended that, of course, screening is cost-effective when we diagnose a bicuspid valve. We should do family screening because it is cost-effective. 10% of relatives are asymptomatic in patients with a bicuspid valve, and especially given this risk factor associated with the root and the higher incidence of bicuspid valves in patients with genetic aortic pathology. When the root is affected, it is indeed recommended with a much stronger indication for family screening. Clearly, the level of scientific evidence is based on a single study, but due to all the evidence regarding the root morphotype, we believe it should be recommended with a stronger indication than when the root is unaffected. And the risk factors are the same as I mentioned earlier for ascending aortic aneurysm. From this point, as I have already mentioned, we have included many follow-up algorithms. In this case, the indication for surgery with all the indications I have provided among the 50 and 5 millimeters, and how to follow up with patients who have an aortic aneurysm. We introduce different indications depending on whether the growth is greater if the phenotype affects the root or the ascending aorta, or if the patient has a bicuspid or trileaflet valve. Based on all this, we establish a different follow-up and different classes of evidence for the indication of surgery. I won't elaborate on the algorithm, but it is an algorithm that allows for a more tailored follow-up of patients with aortic diseases. The next point is that when a patient has a pathology, an aortic dilation, the next question is whether we should consider if this is an individual aortic dilation or if the patient may be dealing with aortic dilation of genetic cause. Evidently, if the aortic dilation is familial, it can be either syndromic or not. If it is syndromic, it is much easier. However, it is established that patients with genetic aortic pathology or high suspicion of genetic aortic pathology should be managed in an individualized approach and should be referred to centers with high expertise because it is not straightforward. We also establish an algorithm for when to suspect that a patient has a high incidence of genetic aortic pathology. We begin with age. If the patient is younger than 60 years old and the patient has presented with an aortic dissection, we must suspect that the patient has a genetic aortic diseases at least. We should suspect it and examine it thoroughly. If the patient does not have an initial aortic dissection, the next step is to check for dilation and hypertension. If there are no risk factors, they do not have hypertension, we should also suspect that they have a genetic aortic diseases. If they do have risk factors, then we should focus on the diameter. We should focus on whether the Z-score is greater than 3, keeping in mind that the incidence of a Z-score greater than 3 is less than 0.4% of the population in general. Or if they have additional risk factors, such as having aneurysms at other levels or sudden deaths in the family, familial thoracic disease or syndromic conditions. If they have a high Z-score or risk factors, we should definitely refer this patient to a center of expertise. If the patient is above 60 years, the likelihood of atherosclerosis here is higher. We come back to the same issue. If the patient has dissection or a Z-score over 3, which is quite rare in the general population. If there are no cardiovascular risk factors, we should consider they might have it. If they have cardiovascular risk factors, such as hypertension or atherosclerosis, it could be the primary cause. We would only refer them if there are evident risk factors for genetic disease. Once the patient is referred to an experienced center, it is recommended to screen first-degree relatives with an echo, and we also need to conduct a study, genetic testing in the individual at risk. Then, we will manage this patient based on the genetic results. Furthermore, it is advised to screen all family members. If the genetic study is positive, we should conduct genetic testing for all relatives when we have the results of the genetic study. It is recommended that if we have genetic results, we manage the patient based on those genetic findings. When we have a patient with suspected genetic aortic diseases, even if they do not exhibit any of the signs I discussed earlier, following the previous algorithm, if we suspect genetic aortic disease, even without a family history or a significant genetic variant, the patient should be referred to an expert center. They should be sent to an experienced center, and screening with an echo should be done for first-degree relatives. When should we conduct family screening? It should be done when the patient has had an event like dissection. We should not begin screening for relatives, such as children, until we recommend starting screening at 25 years old. Or 10 years before. The age they experienced the dissection or aortic event, the index case. This study should be performed every 5 years until the individual turns 60. As I said, management must be based on genetic results. I won't go into detail since this is very specific, but we do emphasize the follow-up, what tests need to be done, how often and when surgery is indicated for patients with fibrillin mutations or TGF-beta mutations, what types of tests and how frequently should they be done to ensure the most specific follow-up for these patients. Additionally, based on all the evidence published in recent years, we aim to optimize the prognosis for patients with Marfan syndrome. Recent studies have been published, including one conducted here called LOTE. There is now clear evidence that patients with Marfan syndrome should be treated with beta blockers or ARBs to prevent aortic dilation and slow its progression. Some authors claim that they should be treated with both medications, particularly in several circumstances, but here the evidence is weaker. In the guidelines, we stress the evaluation of patients with Marfan and their desire for pregnancy, which has been a growing focus recently. Here we have started rehabilitation and promoting physical exercise for patients with Marfan syndrome or genetic aortic conditions, as it has been seen that exercise can be advantageous in these cases and for aortic conditions overall. It is more harmful to avoid exercise in these cases than to adhere to a fully supervised and controlled exercise routine. Centers with experience. In the last part of these recommendations and guidelines, we focus on managing acute aortic syndromes. The main classification here is the Stanford classification. We classify it as type A or type B dissection, determining chronicity, whether a dissection is hyperacute, acute, subacute after 14 days, or chronic after 3 months. What is established is that in the classification, when we have a patient with an acute aortic syndrome, currently it is advised to use the TEM classification, the same one suggested by the European Society of Thoracic Surgery. One advantage is that it offers a broader assessment of aortic dissection in these situations. First, it starts by determining where the dissection is located, whether it is type A, type B, or type A not involving the arch exclusively, or retrogradely up to the arch without reaching the ascending aorta. This is important because they have different approaches. Thus, we do not lose this classification as the first part of the dissection type. The second aspect is determining where the entry point is, which has prognostic implications for follow-up and diagnostic ones as well. If we find that the entry point is in the arch, we can perform surgery in the acute phase involving the arch's entry point. We may not be able to cure it, but we can almost cure this patient because we will certainly prevent the progression of the disease during follow-up and also the presence of malperfusion. Using the entry tag, we can clearly set this up. Hence, it's vital to gather all this initial information because we can capture a snapshot of the patient right away. We can know what the patient's in-hospital mortality will be, regardless of whether we perform surgery or not. If a patient has no complications and it is a dissection that we intervene on, the mortality will be 4.4% if all conditions are optimal. If complications begin to occur, like malperfusion, for example, then, even with surgery, we will face a mortality rate of 30%, and if the patient comes in shock, even with surgery, the in-hospital mortality will be 56%. How we approach the management of patients suspected of having acute aortic syndrome. These are the fundamental problems of these patients, and we take time to diagnose them. It takes a while. To refer them to a surgical center, and for this we establish that the evaluation of these patients or their approach must be done in a multiparametric way, utilizing the aortic dissection risk score, and we set this with a class 1 indication. We will explore what this approach entails. First, it is recommended, and there is substantial evidence that the aortic dissection detection score is a score that really works when diagnosing which patients with chest pain are suspected of having aortic dissection. This is based on 3 fundamental elements. Obviously, if the patient is high risk, especially with a family history of aortic conditions, if they have Marfan syndrome or if they have known pathology, aortic, or the patient has a base aortic aneurysm or has recently undergone manipulation at the aorta, in this case, we would provide a score of 1. If the pain is typical, it is abrupt, intense, and radiates to the back with high intensity, it would also be a suspicious pain, and we would give it a score of 1. It also appears with some signs of high risk, such as hemodynamic instability, perfusion alterations, and neurological changes, which we would also consider A. We would increase the score if the patient has 1, 2, or 3 points, and based on this we would establish whether the score is 2 or more. If the suspicion level is high at 2, the patient should be referred directly to a CT scan, ideally a synchronized one, to prevent any alterations, pulsatility, and avoid mix-ups. If the patient has a risk lower than 2, it is clear that a more complex examination should be performed. With the electrocardiogram, chest X-ray, and a focused echo, if we can, The D-dimer, which we know is a D-dimer less than 500, essentially excludes dissection. And with the integration of these tests, if any of them is positive, then perform a CT scan to confirm or rule out the diagnosis. We also establish treatment guidelines once the diagnosis of acute aortic syndrome is confirmed. Initially, always with beta blockers to slow down, to reduce what is known as DPDT, meaning heart rate and pulse wave velocity, with beta blockers to reduce DPDT. Because if we introduce more dilators at the start, we could increase DPDT and worsen the situation. Start with beta blockers with the aim to keep the heart rate under 60. And of course, control the patient's pain, as this can also lower heart rate and blood pressure. If the patient remains hypertensive after these steps, I would use vasodilators to get the pressure under 1. In cases of poor perfusion, we aim for the lowest blood pressure possible to ensure that organ's perfusion. Then we establish a surgical treatment plan for these patients based on whether there is aortic rupture or complications. Based on the type of dissection surgery and whether there is poor perfusion. We start first with the classification of the dissection or aortic syndrome. If it is type A, then surgery is what we need to do. If it is type B, we must assess if it's a complicated type B dissection, meaning checking for poor perfusion, aortic dilation in the acute phase, or refractory hypertension. If there's refractory pain, we suspect a complicated dissection, and endovascular treatment is preferred if possible. If not, then surgical treatment is necessary. If these signs are absent in the acute phase, we would consider it an uncomplicated dissection, and we would determine that if high-risk signs are present. This is more up for debate, and some may argue otherwise, but there's growing evidence, and in this hospital we've conducted many studies showing that when high-risk signs exist, the chance of the patient dilating in the subacute phase is quite high. Therefore, when these high-risk signs appear, we see that close monitoring of the patient is necessary, and if dilation occurs, the recommendation is to consider, if the patient has a good prognosis, to try endovascular treatment in the subacute phase, certainly not with a class 1 indication, but several studies showed the predictors to indicate endovascular treatment in a subgroup of patients with higher risk of complications. And if endovascular access is not possible, then to conduct earlier follow-up to determine if open surgery is needed, and if there's no high risk, we will then follow up medically with the risk factors and managing hypertension and all the known cardiovascular risk factors. In patients with intramural hematoma, the same approach I mentioned earlier applies. When it is a complicated type B dissection, clearly we can favor endovascular treatment, and we should also mention that in patients with a type A intramural hematoma, when there are no images or signs of high risk, meaning the aorta is not over 50, affecting the distal aorta but not the root, and the patient has a good prognosis, and so forth. Thus, if there are no complications and the outcome is positive, we can manage it conservatively, waiting to see, and many of these patients might reabsorb and not need surgery in an urgent phase. Therefore, as fundamental messages of these guidelines, as we clearly want to emphasize, indicate that when we have a patient with vascular involvement at the peripheral level, carotid, iliac, etc., or an aortic involvement, we need a global assessment. It is important to screen for aortic diseases to assess when a patient may have genetic aortic disease to avoid complications and maintain strict control of risk factors. We must remember that patients with acute aortic syndrome need a rapid diagnosis and a strict hemodynamic and pain control management. Overall mortality rate could be higher than 30%. Thus, these patients are very high risk and need proper management. A good approach to aortic diameters should be quite concise, as we do in this center. for homogenization and comparison of warning signs. When suspecting genetic disease, the algorithm I have explained allows us to manage patients according individual genetics, tailoring the treatment accordingly and individualize that follow-up. Most importantly, a high level of suspicion is necessary for patients with acute aortic syndrome, as I discussed in the outline. Additionally, we should enhance the endovascular approach whenever possible and when high-risk characteristics are present.